whoever's here.
Hello, everyone, and thank you so much for joining our meeting. We will start today's meeting, and Dr. Eiman will be moderating this meeting. And it's up to you. I will hand it for you, Dr. Eiman. Go ahead. Thank you.
Thank you, Dr. Nader. Hi, everybody. I hope you're all doing well. Well, today's dialogue team presenting. We have 4 topics. We're going to speak about heart failure, and we'll have a presentation about how to create a better research poster. Also, how to write a letter to the editor presenters. And lastly, we're going to speak about the open AI concept. Our first presenter is Dr. Isra Hamza, who's going to present heart failure. So if you're ready, Dr. Isra, you can go ahead and share your screen.
Hello, everyone. Just a second. I will start sharing my screen.
No problem. Take your time.
Okay. Okay. Are you hearing me, everyone?
Yes.
Assalamu alaikum. Our talk today is about heart failure. Today, we are going to describe the epidemiology, etiology, and pathophysiology of heart failure, also the clinical signs and symptoms of heart failure as they manifest in older adults, and appropriate management strategies, and finally, how to provide end-of-life care with consideration of individual patient prognosis. Just a second. Okay. Epidemiology of heart failure. Incidence of and prevalence of heart failure increase with age. The leading cause of hospitalization and re-hospitalization in older adults is heart failure. Median age of patient hospitalized with heart failure is 75 years, and approximately 2/3 of those of deaths attributable to heart failure are in patient age 75 years or older. So heart failure is the major cause of chronic disability and impaired quality of life in elderly people. Etiology of heart failure. Heart failure in older adults is often multifactorial in origin. The first main cause is hypertension in both men and women. Next cause is attributable to coronary artery disease. Other common causes include valvular heart diseases and non-ischemic dilated cardiomyopathy. Heart failure with reduced ejection fraction. Heart failure with reduced left ventricular ejection fraction is mainly less than 40% left ventricular ejection fraction. Nearly 90% of heart failure patients less than 65 years old have this form of disease. Heart failure with preserved ejection fraction, that means that the left ventricular ejection fraction more than 40 to 50%. So the reduced ejection fraction less than 40%, and the preserved one is from 50 to 40%. Affects 40% of men and 2/3 of women more than 65 years old with heart failure. Just a second. Sorry. Heart failure with reduced ejection fraction, often atypical and non-specific. Most common symptoms of those patients are exertional shortness of breath, fatigability, orthopnea, and lower limb edema. Exertional symptoms may be less prominent in older people because they often have sedentary lifestyle. So the prevalence of atypical symptoms increase with age. Decreased mental acuity, confusion, lethargy, irritability, anorexia, and abdominal discomfort, all altered constipation or diarrhea. And as you notice, all those symptoms are non-specific. How to investigate patient with heart failure? Standard chest X-ray remains the useful initial test for detecting pulmonary congestion or pleural effusion, and also to exclude pneumonia as a cause of shortness of breath in elderly. Other is B-type natriuretic peptide, the PMB. PMB and its precursor N-terminal pro-PMB are available in establishing diagnosis of volume overload due to heart failure, and in particular in distinguishing shortness of breath due to heart failure from that attributable to non-cardiac cause. However, specificity of PMB decreased with age. So how to control and how to manage patients with heart failure in elderly people? The goals are to decrease symptoms and improve the quality of life. Also to reduce the acute exacerbations requiring hospitalization and eventually to increase survival. Hypertension, hyperlipidemia, and diabetes should be treated in accordance with current guidelines. Also, stop smoking or smoking cessation should be strongly encouraged and supported if indicated. In addition to alcohol intake should be limited to not more than 2 drinks per day in men and 1 drink per day for women. Non-pharmacological therapy include heart failure patients have long been counseled to restrict dietary sodium intake to less than 2 grams per day. Low sodium diet have been linked to worse outcome in several clinical trials, and little data exists on optimal sodium intake. Most patients with heart failure should also engage in regular exercise, such as walking, stationary cycling, swimming, or water aerobics. Exercise duration and intensity should be adjusted to the individual patient's level of conditioning, severity of heart failure, and comorbidities. Patients should keep ongoing record of their daily weight. So they should record their weight every day. Regarding pharmacology therapy, optimum treatment usually requires more than 3 medications, and in some cases up to 7 medications. Almost all patients take no less or more than 1 additional medication for coexisting illnesses. The problem of these multiple medications is adherence, and addition to high potential for drug interactions and adverse side effects, and lastly, the cost. Therapy must be individualized according to each patient. Consider the multiple factors that influence the quality of life and other desirable clinical outcomes in older adults who have multiple chronic illnesses and limited life expectancy. In general, first drug is ACE inhibitor. In general, start treatment at the lowest dose and gradually titrate to maintain the dose as tolerated by the patients. Contraindication of ACE inhibitor include non-intolerance to this medication, in addition to hyperkalemia, hypotension, and several renal insufficiency in patients not currently undergoing dialysis. Common adverse effect in patients taking ACE inhibitor includes cough, 50 to 10% of patients during long-term treatment. In addition to mild worsening of renal function, often transient, also hyperkalemia, hypotension, GIT distress, and rarely angioedema. Although angioedema is rare, but it's very serious and it's absolute contraindication. It's absolute indication to stop taking ACE inhibitor and move to the next medication, which is angiotensin receptor blockers. ARBs are the option for heart failure patients who are unable to tolerate ACE inhibitors because of cough, allergic reaction, or GI disturbance. ACE inhibitor and ARB. I just can't see the title on top. Emma, do you see it?
Sure, it's beta blockers for heart failure.
Thank you. As with ACE inhibitors and ARBs, treatment with beta blockers should start at the lowest available dose and gradually titrated to maintain the dose over several weeks. Contraindication of beta blocker includes severe decompensated heart failure. We don't start with beta blocker in patients with acute heart failure. Second is active bronchospastic lung disease, including chronic obstructive lung disease and asthma. Also patients with marked bradycardia and relative hypotension, and patients with significant atrioventricular nodal block and non-intolerance to beta blocker. Okay. Emma, again.
Sure.
Title?
Angiotensin receptor blocker plus nitroprotein inhibitors.
Okay, and this is the sacubitril. Sacubitril acts to raise the level of several endogenous vasoactive peptides, including nitrotic peptide, bradykinin, and adrenomedulin. Valsartan plus sacubitril can be used as an alternative ACE inhibitor or ARBs in persons with heart failure, reduced ejection fraction, and New York Heart Association class 2 or 3 symptoms, who have previously tolerated treatment with ACE and ARBs inhibitor. So we start with ACE inhibitor, ARBs, and the next one is sacubitril. Contraindication of sacubitril is angioedema, adverse reaction. The ARNI may be associated with mild worsening of renal function, hyperkalemia, and hypotension. Emma? Diuretics. Essential component of heart failure therapy in most patients is diuretics. Most effective agent for relieving congestion and pulmonary congestion and edema. In general, diuretic dose should be adjusted to maintain euvolemia, so we should be very careful. Manifested by absence of pulmonary arrears and SC, third heart sounds, gallop, increased jugular venous pressure, hepatojugular reflex, and peripheral edema. Aldosterone antagonist, spironolactone, has been shown to reduce mortality and hospitalization in patients with New York Heart Association class 3 and 4 and patients with left ventricular ejection fraction less than 30%. Selective aldosterone antagonist is elafibranor, has been associated improves the outcome in patients with recent MI complicated by heart failure or reduced ejection fraction of left ventricle by less than 40%, and in patients with New York Heart Association class 2 and heart failure, it will reduce ejection fraction less than 35%.
Potential aldosterone antagonist.
Okay. Oh, thank you. Older adults are increased risk of acute renal injury in addition to hyperkalemia, including deaths from these conditions. So patients with heart failure and have been impairment of renal function and hyperkalemia should be very careful in using spironolactone, although it reduces hospitalization. Checks serum potassium and renal function 2 to 3 days and 7 days after initiation of treatment. And contraindication is again, it's patient with creatinine more than 2.5 and serum potassium more than 5. Digoxin improves symptoms and reduce heart failure hospitalization in patients with heart failure, reduced ejection fraction, but does not decrease mortality. Target of digoxin concentration from 0.5 to 0.9 nanogram per ml. Adverse effects include nausea, visual disturbance, and cardiac arrhythmia. And you know that digoxin is associated with adverse effect with calcium channel blocker, so we should be very careful. The combination of hydralazine and nitrate is recommended for heart failure patients with contraindication to ACE inhibitor or ARB and in plaque patients with advanced heart failure as an addition to ACE inhibitor and beta blocker therapy. Emma?
Other therapies for heart failure.
Current guidelines therefore recommend against routine anticoagulation. Yeah, this is about anticoagulation. So current guideline recommends against routine anticoagulation in heart failure patients with absence of atrial fibrillation. For heart failure patients with comorbid atrial fibrillation, long-term anticoagulation with warfarin or one of newer oral anticoagulant is indicated in most cases.
Pharmacotherapy.
Mm-hmm.
Pharmacotherapy for heart failure with preserved ejection fraction.
Okay, so optimum therapy remains undefined. Current recommendation is aggressively treat hypertension and other factors, many comorbid coronary artery disease, maintain sinus rhythm or effective rate control in patients with atrial fibrillation, and also cautiously use diuretics to maintain euvolemia while avoiding overdiuresis. Many of these patients are volume sensitive.
Implantable cardiac defibrillators.
Okay. ICD, it reduces mortality from sudden cardiac death in patients with heart failure and left ventricular fraction, the ejection fraction less than 35%, regardless the cause of heart failure due to ischemia or non-ischemic cause. Prophylactic replacement is advised for patients with New York Heart Association class 2 or 3 heart failure or left ventricular ejection fraction less than 35%, in addition to life expectancy more than 1 year with good functional states. Deferred ICD implantation for more than 40 days after acute myocardial infarction and more than 90 days after new diagnosis of dilated cardiomyopathy. In new diagnosis dilated cardiomyopathy, the left ventricular function often improves after initiation of beta blocker and ACE inhibitor therapy. So we can wait up to 90 days to insert the ICD. ICD implantation mortality benefit decline with age due to competing risk of death, and the risk of complication from ICD implantation is greater in older adult. Proactively discuss disabling device near end of life. Biventricular pacemaker is cardiac desynchronization, right, Ima?
Cardiac resynchronization.
Resynchronization, sorry. Biventricular pacemaker with one lead in the right ventricle and the second lead inserted retrograde into the coronary sinus to stimulate the left ventricle. So we have two lead, one on the right ventricle and the other one on the left ventricle. Indicated in patients with desynchronous left ventricular contraction, most commonly related to left bundle branch block, presented up to 30% of patients with heart failure reduced ejection fraction. It improves symptoms, exercise tolerance, the quality of life, and survival in selected patients with advanced systolic heart failure and persistent severe symptoms, New York Heart Association class 3 or 4, despite conventional medical therapy. So we start with medications and then we watch the symptoms of the patient. If there is no improvement, if there is ejection fraction less than 30%, if there is left ventricular branch block, this patient is candidate for biventricular pacemaker.
Recurrent hospitalization.
Recurrent hospitalization in patients with heart failure, up to 50% of patients with heart failure are readmitted within 6 months after initial hospitalization. Only 1/3 are readmitted with chronic congestive heart failure as the primary reason or readmission. Common alternative reason for readmission includes pneumonia, chronic obstructive pulmonary disease, sepsis, and other cardiovascular conditions, including acute myocardial infarction. Patients who experience recurrent heart failure hospitalization should be questioned carefully and educated appropriately about adherence to medication and recent change in weight, in addition to recent dietary choices and daily fluid intake.
Prognosis.
Prognosis of heart failure, the median survival rate of 2 to 3 years. 25 to 30% of patients die within 1 year after initial diagnosis. 50% survived 1 to 5 years, and 20 to 25% survived more than 5 years. Women with heart failure are somewhat better survival rates than men, and patients with heart failure reduced ejection fraction.
End-of-life care.
Okay, end-of-life care counsel patients to prepare an advance directive, which may include the appointment to surrogate decision maker and the delineation of intervention desired or be avoided in the event of clinical worsening or approaching death. Ask patients with ICDs to indicate under what conditions they would want the ICD turned off to avoid repetitive painful shock at the end of life. In patients with particularly poor prognosis and remaining life expectancy less than 6 months, offered option of transition to hospice as a part of candid discussion about prognosis and goals of care.
Choosing wisely.
Okay. Heart Rhythm Society, they said don't implant an ICD for the primary prevention of sudden cardiac death in patients unlikely to survive at least 1 year due to non-cardiac morbidity. And American Academy of Hospice and Palliative Medicines, they said don't leave ICD activated, which is inconsistent with the patient family goals of care. American Society of Nephrology, they thought that avoid non-steroidal anti-inflammatory drug in individuals with hypertension or heart failure or chronic kidney disease of all causes, including diabetes.
Summary.
In summary, heart failure is the leading cause of hospitalization in older adults and a major source of chronic disability. Older patients with heart failure are more likely to be women and more likely to have preserved left ventricular systolic function. ACE inhibitor, ARBs, beta-blocker, aldosterone antagonists, and in selected patients, hydrazine and nitrate combination reduce morbidity and mortality from heart failure reduced ejection fraction. Non-pharmacotherapy for heart failure patients have been definitively shown to reduce mortality. Optimum management of heart failure in older patients often require multidisciplinary approach. Any question at this point? Any question or comment? Okay, now we can move to the cases. 73-year-old woman come to the emergency department because he has worsening shortness of breath. He has had increased difficulty with daily life activity for 1 month and dizziness for minimum exertion for 10 days. He has been hospitalized 6 times within the last 6 months for dyspnea, chest pain, and lower leg extremity edema. History includes chronic coronary artery disease, peripheral artery disease, renal artery stenosis, and diabetes. Medications include aspirin, clopidogrel, carbidopa, lisinopril, isosorbide mononitrate, and furosemide. On examination, blood pressure is 161/112, heart rate 114, respiratory rate is 24. PUN 24, creatinine increased from normal to 1.57. Echocardiography shows dilated left ventricle with ejection fraction 20%, in addition to moderate mitral regurgitation. Intravenous furosemide is administered and bi-level positive airway pressure is ordered for hypercarbic respiratory failure. Which of the following intervention is least likely to improve this patient quality of life and reduce risk of subsequent readmission? A, palliative care consultation. B, enrollment in heart failure disease management program. C, initiation of intravenous inotropic therapy. D, initiation of sacubitril valsartan. Anyone? Anything in the chat, Ima?
No, not yet.
Not yet? Okay. Can wait for a while. What is the least likely to improve this patient condition? Okay. She has shortness of breath, dizziness, recurrent hospitalization, history of chronic artery disease, peripheral vascular disease, diabetes, She's on optimum medication to this point. She's hypertensive and tachycardic and tachypneic with minor renal impairment. What do you think, everyone? Should I go for the answer?
You have an answer of a D.
Okay, initiation of. Okay, so the question is least likely to improve the patient quality of life. Okay. All right.
You have B as well.
Okay. Okay. The answer is least likely improve the quality of life is initiation of IV inotropic therapy. The answer is C. A 77-year-old man was discharged 1 week ago from nursing facility where he recovered from below knee amputation to his left leg. At the nursing home, he gained weight and mild ankle swelling developed. Medical staff added bomitanide to his drug regimen. Since returning home, he had increasing dyspnea with activity and orthopnea. Edema has progressed to his lower limb with possible dehiscence at the amputation site. History includes ischemic heart disease, ischemic cardiomyopathy with ejection fraction 42%, coronary artery disease, diabetes, peripheral vascular disease. 4 vessels, coronary artery bypass graft 10 years ago. Medication includes aspirin, hydralazine, isosorboid dinitrate, insulin, galagreen, insulin aspart, lisinopril, bomitanide, and carvedilol. Examination, blood pressure 129/70, heart rate 77, respiratory rate 18, bilateral edema in lower extremities, BUN 27, glomerular filtration rate 57. Which of the following would be least appropriate for managing this patient congestive symptoms? A, restrict sodium intake to less than 1.5 gram per 24 hours. B, restrict fluid intake to less than 2 liters per 24 hours. C, double the dose of bomitanide. And D, add metaluzan 5 milligram daily. Anyone?
You can
Do
go
you have
back
answer?
again, it would be helpful.
What?
If you can go back to the question again.
Yeah, sure. Yeah, sure. He's 77 man, discharged recently from nursing facility with history of below knee amputation. He gained weight. Edema include both limb. His history include ischemic cardiomyopathy, ejection fraction 42. Also, he undergo graft for his coronary arteries, and his medication. Examination, his blood pressure is okay, heart rate okay, respiratory rate okay, bilateral edema, BUN 27, and GFR of 57. The question which is least appropriate for managing this patient congestive symptoms. Restrict sodium to 1.5 or restrict fluid to 2 liters per day, or double the dose of bomitanide or add metaluzan. Do we have answer, Emma?
Yes, you have answers mainly A and 1B.
Okay, great. Yeah, it's A. So the least appropriate is to restrict sodium intake less than 1.5. Good job, everyone. Any question? Any question or comment? Oh, no.
If nobody has any questions, thank you very much, Dr. Isra. That was a very, very helpful and useful presentation.
Okay, thank you.
Thank you so much, Dr. Isra. This is great and excellent presentation. It's an important topic because you're going to see a lot of patients at the hospital and maybe in the clinic when they want to follow up if you go to subspecialty, also you may see a lot of patients with heart failure. So the goal is to keep them at home, prevent rehospitalization, as mentioned here. And thank you so much again.
Thank you, Albert. I'm trying to stop my sharing my screen. Sorry.
Take your
Okay.
time.
Okay.
We go to your Zoom application. And
You know, I know. Okay, stop here. Yeah, I found it.
perfect. Thank you.
Thank you,
Appreciate
everyone.
Our second presentation is how to create better research poster. It's going to be presented by Dr. Amna Elkhidir. If you're ready,
Hello.
Dr. Amna, you can share your screen.
Okay, I will be talking about how to create a better research poster in less time. Usually small presentation. Okay, the research posters should maximize the amount of insight transferred to attendee in a poster session. So you should design the poster in a way that it grabs the attendee attention to learn more about your poster. And keep the good stuff, leave the time for having conversation. Do not include everything you have in a poster. Always just write concise words. Usually 40% of the poster should be text. The other should be blank. So do not overcrowd the post with a lot of words that no one would actually read. And make it easy. Say it in write it in easy language, not complicated terms. And detailed information should still be present, but not the core of the poster. Always follow the rule that a lot of effort into what people need to know, the main finding of the study. And put the nice to know last. Always put the usual as a major part of your research or the major conclusion of your research in the core of the poster. Like this example here, put the main finding in the core of the poster in a plain English word, not complicated sentences, and emphasize the important words. Okay, here you can put the rest of the posters, the introduction, method, result, and discussion. And here is extra tables and figures. So usually posters divided into 3 parts. Here, the core message. And here, this is called silent presenter bar, where you write the introduction, method, results, and conclusion. And here are any extra tables or figure you want to discuss with the attendee. First, we have the core message. Often a study will have a single sentence, clear takeaway. In traditional poster designs, this is commonly lost in conclusions and easily missed by a conference attendee just strolling past your posters. Place your key message right in the middle of your poster in a huge font and in plain language. Here. Usually the main part of the study or conclusion or discussion that you want everyone to know about your research. The silent presenter part. A colleague had read your core message and interested, so he approached to get more information. This is why you want to impart the information you would put on a typical academic posters, your introduction, method, result, conclusions, or discussion. The goal of silent presenter part is to give an interested researcher the need to know information about your study without you having to be there to explain it. Here, we find the silent presenter part. You put your introduction, method, result, and discussion, so anyone can stand and read it without having you to explain it. The third part is the ammo bar. Your colleague had read your silent presenter bar, impressed by your work, and has come to chat to you for more details. Now that you have their full attention, it's time to use the content of your ammo bar, where you put all the nice to know information. like extra explanation and additional detailed result for people in your subfield that you can point to and explain as you discuss your work with a college. Here we find the AMA bar with the extra tables and figure. If someone is already read your core finding and your silent presenter bar and is interested to know more about your research, you can write everything you need to nice to know in here in AMA bar. By grouping this more complex information together, you can control how people engage with your poster. You write your core message in a plain language, and a bullet point study description second. In silent presenter bar, you can write your introduction methods and result in a bullet point, and the detailed science in the AMO bar. QR code. If someone wants to know more information that you cannot put in the poster, you can make QR code in the middle of the poster. The central part of your poster might have a bit of a space left. In fact, if you have kept your core method short and snappy, you definitely will. A good way to utilize this space by putting a QR code linking to your paper and poster. Here is the link where you can create a QR, and here is the link where you can learn how to link the QR to the paper and a copy of the poster. An example of a poster, like we said, in the middle you write the core message, and there is a space left. You can link a QR code here to the poster and to the detailed paper. Here you have the silent presenter bar where you have the introduction, method, result, and discussion. And here in the AMO bar where you have extra explanation or more tables and figures if someone is more interested to know more about your research. The clearer your message, the more people will remember and engage with your research, and that is what all poster sessions are about. Here, just a repetition of what we said. Replace titles by statements that get directly to the point. For example, if you see here, this title, using linguistic analysis tools to study teams in ICE environment, it's a little bit more difficult to absorb. We can just say linguistic analysis tools can predict social conflict in teams. This is plain language everyone could understand, and it's also looks like it's from the conclusion part of the study. Translate into casual conversation language. For example, if we say negative effect inhibits attention and performance, this is like dull sentence. You can say in easy word, bad mood distract people at work and lowers their performance. It's a bit more understandable. And you can use image also. Like here, we attach an image. This helps people elaborate your finding in their mind. Always remember to use colors, maybe 3 to 4 colors for the whole poster. And be careful for the font that if you are invited to a specific conferences, follow their guideline and attach key figures. Thank you.
Thank you, Dr. Amna. Thank you for that.
Thank you so much, Dr. Amna. This is also a great presentation and to the point. And I think this is another way of doing your posters. In the past, they use different ways. You divide the poster into 3 columns or 2 or 4 columns, and then you add the text, then you add the images or the graphs or tables. So this is a better way, catch the attention, and then if they are interested, they can read more, and the QR code will help. Before we jump to the next topic, maybe we can see if how we can do the QR code online. There is a way to do it in Excel. There is a way to do it in Google Sheet, but the web link that you mentioned, the monkey link, I think it's a better way. And the reason, sometimes you may want to match the color of the QR code to the color of the abstract. Let's say we have a green background in the abstract, and we want to focus on the green and white. So if we want to use a QR code, maybe instead of putting it as a black and white, we can color it green and white. Let me see if we can do that here. Let me share the screen with you guys. So here's how you do the code. For example, you want to add a URL or your email or your contact information, or maybe some text. You can add the information here, or however you want to add the content. And then you can set the colors. So you can change different colors according to what you want. And it will change it somewhere there. When you create here, it will change it to the color you want. I want it red, you can put it somewhere red, for example, and then color, and it will become red. So this is a different way of matching your poster theme or color theme with a QR code. Just a way to add to the great presentation. Thank you again for doing this for us. Thank you.
Yeah, it was very, very informative presentation. Thank you very much. Our next presenter is Dr. Mohamed Osman. He's going to be presenting how to write a letter to the editor. Whenever you're ready, you can share your screen. He's not here. Dr. Osman. Maybe he's not here, or he's going to join whenever he gets a chance. We can move on to the next topic. We can talk about OpenAI, which I'm going to be presenting. So I'm going to share my screen. All right. Can you see my screen?
Yes.
So this is a very, very interesting topic. I was actually did not know about it before, so it was very interesting read to me. So OpenAI, first we need to basically identify artificial intelligence and see what is OpenAI basically. So artificial intelligence is intelligence perceiving, synthesizing, and inferring informations demonstrated by machines, as opposed to intelligence displayed by non-human animals and animals. To understand what OpenAI is trying to do, it's basically taking a branch from the AI, basically artificial intelligence, which is called generative artificial intelligence. That refers to the artificial intelligence that can generate novel content rather than simply analyzing them or acting analyzing or acting on existing data. So basically, it's not just about learning. We're not just giving the AI informations and they interpret it. In actuality, we give them a lot of data and we give it a lot of data. And with this data or with enough data, they can be able to generate and create new things that did not exist before. While this was not first attempted by OpenAI company, this company now is the leading front of the GAI, which is generating AI research. OpenAI is an American artificial intelligence research laboratory. It's a company that conducts research in the field of AI with the stated goal of promoting and developing friendly AI in a way that benefit humanity as a whole. Taking from their website, their mission is to ensure that artificial general intelligence, by which we mean highly autonomous systems that outperform humans at most economically valuable work that benefits all humanity. So basically, they want to create an AI system that would be useful in the day-to-day life, in businesses and research, and that everybody can use. They have many features. The three prominent ones is DALE2. It's an AI system that can create realistic images and art formed from a description of natural language. So basically what we can do is we can, when you open it, you just give them a description of a word, of an image, basically, that you want to create. You can say a horse wearing a hat. They will create a horse wearing a hat that never existed before. It's not that they're just going to search for an existing image of a horse wearing a hat. They can create the image by combining a hat and a horse. There is, if I may share a YouTube video that explains it very well. I'm not going to show the whole thing. It's just a minute to see how it works, if it's okay.
Or robot painted like a Picasso? Didn't think so. DALL-E 2 is a new AI system from OpenAI that can take simple text descriptions like a koala dunking a basketball and turn them into photorealistic images that have never existed before. DALL-E 2 can also realistically edit and retouch photos. Based on a simple natural language description, it can fill in or replace part of an image with AI-generated imagery that blends seamlessly with the original. It's called inpainting. In January 2021, OpenAI introduced DALL-E, a system that could generate images from text, like this avocado armchair. DALL-E 2 takes the technology even further with higher resolution, greater comprehension, and new capabilities, like inpainting. It can even start with an image as an input and create variations with different angles and styles. DALL-E was created by training a neural network on images and their text descriptions. Through deep learning, it understands individual objects, like koala bears and motorcycles, but learns from relationships between objects. And when you ask DALL-E for an image of a koala bear riding a motorcycle, it knows how to create that or anything else with a relationship to another object or action.
Could you hear the video?
Yes.
Okay, so I just wanted to share that because honestly, I was very, very amazed by it. It's as you can see, there is a lot of application that we can use this in. It's very, very intelligent, basically. one of the other features that this OpenAI has is Whisper, which is an automatic speech recognition system trained on over this number of multilingual and multitask supervised data collected from the web. The Whisper is quite useful in basically helping in translating and recognize speech, basically. So one of the applications that they use it in translating from any language to English. They also use it. It has the potential to be used when, in situations where technically you want to hear what other people are saying in like high security situations, or you want to interpret or isolate specific speech from a noisy background. The most used and known and very, very interesting one is the ChatGPT. It's a model that interacts in a conversational way. The dialogue format makes it possible for ChatGPT to answer follow-up questions, admit its mistakes, challenge incorrect premises, and reject inappropriate questions. The ChatGPT is one of the main ones that people are now using. This on the first 5 days of it dropping in 2022, more than 5 million joined the app. It is considered one of the innovations for the next era of technology, basically. It is quite impressive in the sense of you can basically have a normal dialogue. It does not feel like you're talking to an AI. It feels like you're talking to a person who is giving you information. You can go to the application, you type in whatever question you have, and within minutes, they will give you a very comprehensive answer that does not feel like it was generated by an AI. You can continue a conversation with them, carry a conversation with the AI, basically, asking follow-up questions. If you give them a wrong information, they can correct it. So it's quite impressive. This application, the AI, the OpenAI applications or features, they have some limitations and challenges that basically that people are not in peace with. Some of the limitations that they have currently is that it may produce incorrect or inaccurate information, because at the end of the day, you provide, us as humans provide the information to them. We give them the data. It can be a very large data. They can combine informations. However, if we provided our own data to them, to the AI, it will give us a wrong information. For example, if we have an olive, and instead of olive, we named it an apple. Whenever you ask them whenever you ask it about an olive, they will not recognize that. And one of their limitations is that it's very sensitive to rephrasing. So basically, you can say a sentence that they would not recognize. However, if you say it in a different way, they may recognize it, or the opposite. This comes from the same place where no matter how much data they have, at the end of the day, it is limited to what we provided. Just like a child, if they don't know a specific word or were not exposed to it, a child, if you ask a child about the savannah, they will never know what that. So it's the same concept, basically. The good thing is it can be improved with every update. It will have more information. One of the things that are very, very dangerous about it is that it may produce harmful instructions or biased content. For example, people used it to ask about how to create the Molotov bombs, basically. They are working on basically creating a limitation on inappropriate questions or creating inappropriate contents. However, humans have a way to basically outspeed the goodness of things. So people with everything that is people can put in questions, it will give them the answer. They would recognize the harmful, that people behind it, humans behind it will recognize that it was a harmful content, and they, in the next update, they can take it out. One of the things that they are worried about is the privacy violation, especially that is now some other companies are joining with them with OpenAI, and they're selling them data and information that we provided. Let's say the application Shutterfly that basically we use when we upload photos or take photos. Like if you went to JCPenney and took a photo, they uploaded it to Shutterfly. They sell them those informations. If they have these informations, basically, or these images, they can create images using your face. So in this way, they can target people with creating fake videos, fake images. They can target people by creating propaganda videos, propaganda images. So these are one of the things that people have challenges with. The other big thing is there is an ethical dilemma in using it, because if you use especially the GPT one, if you said if when you use it, you can look up any answer. If you have an exam, you can look up the questions of the exam. They will give you the answer. You can ask them to write an essay. They would give you an essay. The people use it to create codes. People use it to create a whole research articles. While it, sorry, maybe someone is saying something. Oh, it's available. Okay, they're saying ChatGPT as of today turned to a paid subscription. Exactly, yeah, it was turned to a paid subscription. The free version still works, but isn't always available due to server overload. That is correct. Yes. Whenever you go for the free version, they will tell you that leave your email, and whenever it's available, we can send it to you. I will send you a notification to come and use it. So yeah. So this is one of the ethical dilemmas that people are having with that they can create essays, articles, research. They can give answers for medical scenarios. And actually today, not today, 2 days ago, the AI passed the USMLE examinations. So people were saying that now we can use AI basically instead of physicians, or at least replace the deficit that is happening here. So, and that in itself is an issue, because other people, when they uploaded questions, medical questions, one of the answers was, you should go kill yourself, which is definitely not a good advice. So it's still work in progress, basically. In conclusion, in spite of the limitations and concerns that it have, many of the people in the tech world see the generative AI as the new era defining innovation. They consider GPT as a look to the future. So it's definitely very scary, and it can have a lot of harmful effects. However, it is the case with all technologies. When people started internet was a big issue with it, a lot of concerns. So working on identifying the issues and working on solving them and moving forward with this new technology will definitely provide a lot of help. People use it in many ways. It can be very useful. People can use it in their businesses instead of having to, especially like small businesses, instead of having to hire people for calls. Now it can be an interactive like customer service that can provide a better solutions rather than the one now or having to hire someone. This is one of the examples of how useful it is. Dr. Nader just shared the link for USMLE and AI. It's talking about the experience of USMLE and AI. And last, I'm going to share this PowerPoint with you. The last slide, it has resources, YouTube channels that talks about all the apps in detail. This is the OpenAI website, and this is the GPT website where you can try it if you would like to for free. If you have any questions, I'm open for it.
Thank you so much, Dr. Eiman. This is also excellent and great presentation. The topic is a new topic, and it's going, as you said, viral from day one. 5 million joined the researchers of the team investigating or playing with the chat OpenAI. It's very, very useful, as you mentioned. But it has some scary things or limitation. But as a researcher, we can use it in our research. So what I'm thinking about is we can use it as a training or as a tutorial or as laying out the basics. Let's say I want to write a case, or I want to write an abstract, or I want to write some, so I can get the help as it's a tool. I can ask it the question that I want the tool to help me with, and then I can modify that. So we will use it in the near future, and we'll see how it's going to be helpful for us in this program. Thank you again. Have a
It's
go ahead.
quite interesting. I was very intrigued when I was like reading about it, so definitely gonna try it. Thank you, Dr. Nader. I can see Dr. Mohamed Osman is here. If you're ready, Dr. Mohamed Osman, you are presenting how to write a letter to editor.
Yeah, thank you so much. Thank you so much. I'm just trying to share my screen with you.
Yeah, go ahead.
So today we're going to talk about how to write a letter to editor. So as we know that there are multiple type of research publication we can write and submit to a medical journal. So one of them is a letter to editor. So what is the purpose of what is a letter to editor, and what is basically the purpose of a letter to editor? So letter to editor is basically a excellent platform for sharing fresh perspective and insight, which can invite the dialogue in the academic medicine across the health professionals community. But it is important to mention that it is a brief type of research publication, and the word count is around 400 words or even less. So if we talk about the purpose of letter to editor, so it basically provides an opportunity to discuss the aspects of recently published paper. For example, if you have methodological concerns which may affect the validity, or if you have concerns on the study conduct, or if you have any disagreement with the study interpretation or conclusion, or if you want to seek clarification on any aspect of the research paper, then you can write a letter to editor and then you can address this issue. So then it can also provide you an excellent opportunity to share professional viewpoints and to enrich the existing knowledge of the recently published paper or hot topic with professional opinion or objective data. For example, there is a paper related to such as we were discussing the chat GPT and role of AI in medicine. So if there is a person who is expert in AI and he or she is also a physician or clinician, and then he wants to share his input so that he can write a letter to editor and share his or her perspective. So if we talk about types of the letters, so we can categorize them into two. One is the common type and the other one is uncommon type. So the common type is basically, these are the comments in the form of response to previously published articles, and they can be comprised of positive or negative comments. And it is usually a brief feedback on clinical data or research data, and it can also be a feedback on case reports. If we talk about the uncommon types, so the uncommon type of the letter to editor is basically comments on common medical issues or journals policy, and comments on journals quality or format. And number third is the statement on patient's access to study material or collaborative study. So now we're going to talk about do's and don'ts for a letter to the editor. What are the preferred qualities of a letter to editor, and what are the aspects which we want to avoid while writing a letter to editor? So a letter to editor should be relevant and purposeful, and it should deliver a clear message rather than, it should not be vague or ambiguous. It should be delivering a clear message, and it should be polite. You should not be scornful, or you should not be involving any personal battle while using this type of medium. And it should be structured, well structured, and easy to read. And it should also be adherent to the instructions given by the concerned journal, and you should also be observing the limit of the word counts and the references, figures, tables, because every journal asks for the specific restrictions, such as you can write a letter to editor comprised of 400 words and say four references and one or two figures or tables. So you should be adhering. You should be adherent to these instructions, and you should be also having a good title, which should be captivative and interesting. And if we talk about the don'ts of writing letter to the editor, so it should not be irrelevant or outdated, and it should basically it should give a value, and if it doesn't provide any additional value to the current medical literature, so you should not be writing a letter to editor. There is no need to write. And it should not be hypercritical or aggressive. like obviously you're writing in order to give your feedback, but you should not be hypercritical, and the tone should not be aggressive. And the other don't is it lacks brevity and flow, and it should not be biased. And the repeat point raised in the original paper, this thing should be also avoided. And instead of saying "Dear Sir," you should be saying "Dear Editor," because "Dear Sir" is an outdated terminology. And similarly, more studies needed, and we need to explore this thing. So these are basically very cliche statements, and we should be avoiding these kind of statements. So if we talk about the process of writing and the letter to editor, so it can comprise of 4 stages. Number one is reading. So first you have to read the available medical literature or related to that particular topic. And then you should plan how to write. And the third one is the process itself, writing. And the fourth phase or stage is submission. So if we talk about the plan, so you should be planning the content, you should be doing the literature review, and you should also checking the journal requirements, and you should also deciding the co-authors. And then the writing process, it basically deals with the process of writing itself, that what should be the layout, what should be the pattern, and what should be the tone. So we're going to discuss all these stages in detail in the upcoming slides. So reading, reading is basically the first and foremost and cornerstone step in the process of writing a letter to editor, and like any other publication. So it is basically an inspiration for a letter to editor. It gives you an idea why you are writing a letter to editor. So if you haven't read a research paper, it means you will not be able to write, right? So the process starts from reading, and then you should be reading and reviewing the literature which was previously published. And you should make sure that you have studied, you have reviewed, and you have understood the topic and all the misconceptions, or you think that if there is a misleading point, so you should be making sure that you have studied it thoroughly and you have understood it thoroughly. And then you should be deciding that whether a letter to editor or LTE is genuinely needed or not. Like it should not be just a letter for the sake of writing a letter to editor. There should be a reason, there should be a purpose. And then the next step is reading, and you should be capturing the salient point, such as the strengths and weaknesses and the controversies of the articles. For example, you have studied an article, and it comprises and it contains a lot of confounders, or it contains some misleading points. So you should basically highlight all those weaknesses and controversies which are going to highlight in your letter to editor. And you should also make sure that you haven't misinterpreted all these findings. Sometimes there might be a problem in your understanding rather than the understanding of the authors which wrote the publication. Sometimes you basically fail to understand what they are going to give you the message. So you should make sure that you have understood it properly. And the next stage is planning. So you should perform a literature review to gain a wider understanding of the context of the paper and its discussion point. And it is really important because when you perform a literature review, it gives you various aspects of related to that topic, and it broadens your horizon, and it gives you a new picture to look at the concerned problem. And then you should determine whether there is a novel angle for your letter. Like I said that you should not be just writing a letter to editor for the sake of writing a letter. There should be some reason, there should be some motive, there should be some benefit, and that benefit should be, any novel angle or any discrepancy, any controversy, and then you should raise that point in your letter to editor. And you should also ensure that letter is accepted by the journal. It means that, some journals, they don't accept letter to editor. For example, I can mention that Curious Medical Journal, they don't accept letter to editor usually. So you should also make sure that the journal in which you are writing a letter to editor, whether they accept a letter to editor or not. If they don't accept a letter to editor, it means that there is no point of writing a letter to that journal. And then you should be familiarizing yourself with the manuscript submission guidelines. And each and every journal, almost each and every journal, on their website, they have a section which is known as information for authors, in which they describe all the requirements, like how you should formulate an article, and how you should arrange the references, and which style of references you should use, whether you should be using Vancouver, AMA, or any particular style, and how many references you should be citing, and how many figures or images you can incorporate in your article. So all these informations are really crucial to know, so that you are adhering the instructions, and you're fulfilling the instructions set by the journal. And so another important tip is that if you're writing a letter to a particular journal, you should browse the recently published letters. So it can give you an insight about the format and about the style, then how you're going to formulate, how you're going to format your letter. It can give you an idea what is the standard which is being accepted by that particular journal, and then you can basically draft out your letter to editor. And the next step is a really important aspect and step, that is collaboration with the co-authors. You should team up rather than being a one-man army. You should team up, and you should collaborate with your co-workers or any one you want to collaborate, and then you can divide the workload, and this process can basically make this whole process a lot of easier and convenient and effective to and you can perform this job in a shorter time and in a good manner. But it is important that you cannot incorporate a lot of collaborators or a lot of co-authors. Maximally, you can have 3 to 5 authors in a letter to editor. And one more thing, that you should not be including anyone who has not contributed to the process of writing or to the process of conceiving the idea. So there are set guidelines by the ICJME, which is International Committee of Medical Journal Editors, and they have set the criteria that you should not be including any person who has not contributed significantly and substantially to be labeled as author. So any worker who says that, oh, please put my name in your publication, and you just put his name in the publication. So it is against the research ethics, and you should not be doing it. And now comes the writing the letter and the writing itself. So writing the letter, so you should be avoiding the salutation if the word count is too low. For example, you are running short of words, and in that situation you can remove the salutation. You don't need to say dear editor or something like this, and you just can start right away if you're running short of words. And it is also important to mention that I also mentioned previously that you should avoid an outdated variant that is dear sir. Instead, you should be saying dear editor. And then you should introduce the issue raised or the purposes or any purpose of the letter to editor. Instead of beating about the bush, you should right away state the purpose and issue which you are going to raise in your letter. And you should also mention that what is which is the article to whom which you're talking about, to which you're talking about. For example, if you're talking about any particular article by a particular author, then you should categorically mention it that, you know, my letter to editor is basically concerned with that particular paper, rather than making it ambiguous and vague. You should pinpoint. And it should be focused and brief, and these are basically the key features for writing a successful letter to editor. And then you should basically make the bullet points, and but you should your sentences should be clear and focused and brief. Uh, it should give the clear meaning, and it should be comprehensive, but it should not be very long and lengthy. And an important point is that you should raise maximum 3 to 4 points in your letter to editor. You should not be dealing with a lot of points or with a lot of issues, because the space is limited, and you are also you also have to observe the word count limit. So if you're dealing with a lot of issues and you're going to make points about a lot of topics, then it can give rise to difficulty, and you will not be able to elaborate your points because of the word constraints, word limit constraints. And you can consider structuring the letter by allocating one paragraph to each key point. For example, if you're raising 3 or 4 points in your letter to editor, then you can write one paragraph per issue. You can devote one paragraph for explaining one issue, and then you can devote another paragraph for explaining another issue. And this is how you can complete your letter to editor within 3 to 4 paragraphs, and explaining 3 to 4 points within those 3 to 4 paragraphs. But it is important that you should not be using subheadings while you're explaining all those points. And if we talk about the citations, or citing the recent medical literature or the past medical literature, you should be giving the citations appropriately. And it is important that you should be giving the quoting the references or the articles which are published in the last 5 years. And most of the journals, they require that you should be quoting the recent medical literature, and which was published in the last 5 years, rather than quoting the literature which was published in the older times. And it is also important to mention that you should be avoiding citing your own work and excessively, or it is basically frowned upon if you're using your own work, because they think that you are self-promoting your own work. And the final paragraph should provide a concise summary and end with suggestions or future recommendations. So it is going to basically the crux of the whole letter to the editor. And the introduction, which is basically the beginning and the key point paragraph, the middle paragraph, and the final paragraph, which is the end, they should be weaved together to ensure flow, and it should be maintaining a respectful tone throughout the writing of your letter. And like I mentioned that you should be observing the particular style of references decided by the journal. For example, some journals, they require Vancouver style, some journals they require AMA style. So you should basically check on the journal's website, and then you should arrange your references according to the guidelines of the journal. And submission is basically the final step, and your letter to editor, that is LTE, should be proofread multiple times, and you should also incorporate the proofreading by all the co-authors, because sometimes you just overlook any mistake, and the other person can pick that or detect that mistake before submission, and this would basically make sure that your letter to editor is foolproof or mistake free, and it is going to increase the quality of your research publication. So to summarize that, important considerations while writing a letter to editor, that generally it should be written to deliver objective and constructive comments on the published articles, and it should be brief and conclusive, and it should be non-judgmental, and it should be in a non-aggressive tone. You should not be hyper criticizing the authors. So it was all about writing a letter to editor. If you have any question, you can please ask. Thank you so much.
Thank you very much, Dr. Osman, for having
Thank you so much.
Thank you so much again, Dr. Mohamed Osman. Very good, excellent, awesome presentation, concise to the point, and I hope this will benefit some of you. I think it's a good option to publish and put your name in the literature, like the publication list. When I joined the MSU here at in Lansing at Sparrow Hospital, my colleague, one of them, was interested in subspecialty. So I joined the second year, and he wrote one of these letters to a big journal. So one of the meeting we were sitting, and he's like, "Oh, congratulations!" Everyone is congratulating him. So I was, what's going on? He said, "I just wrote this letter to the editor, and it's been accepted." So, and it's a big deal as far as his pursue for fellowship, and I think it helped him a lot. So it's doable, and as Mohamed mentioned, if you follow the steps, if you are interested in a specific topic or area, if you work hard, you read about the topic, you may find an article that missing some point, or maybe you don't agree, or maybe you can add more from the literature, and then you can submit the letter. It's easier, faster, but it needs some work to be done. Thank you so much for your great presentation, and back to you, Dr. Eiman.
I by this, we conclude our topics today. We can start talking about an update for the projects that are going on now. So if anyone has an update about their project, should feel free to join.
Dr. Nadir, we submitted our poster to AMDA conference, but unfortunately it was rejected. So we're thinking, we the members were thinking that we can send it to another conference or a journal for publication. Is that a good idea?
Sounds good. I think it's a good idea. And that's the way sometimes it work out. Like you try the first conference, and if they don't accept, then you maybe do a little bit of modification and then submit it to the next. The first year we did that, we had, I'm not sure, maybe 7 abstracts or so. We submitted to the AMDA conference. They accepted, I think, 3 and rejected the rest. So we submitted to the AGS. So we got good acceptance rate there. So we can try the same approach. Thank you so much.
So sorry to ask another question. It might be a silly question, but can I know that when it is going to held, the AGS conference?
What it stands for, or what the time?
The time.
The date, I think it's still, I have to look it up, sorry.
Okay, thank you so much.
No problem, I'll update you. So this is supposed to be on my to-do list. We need to put a list of targeted conferences and then the deadline, and we will work as far as plan ahead so that we can submit the abstract on time for these conferences.
Yeah, thank you so much, Dr. It would be great. It would be great.
Yeah, no problem. Good, thank you so much. Anyone else?
Hi, Dr. Nadir. Hope you're doing good.
Thank you.
Our review paper regarding varicella myocarditis, which is being submitted to the curious, like we have received few comments by the editors and we worked on it. So probably this weekend, like our team is going to have a meeting and finalize on the edits. And I'm going to submit that to you as well, such that you could share your thoughts before we finally submit it to the Curious Journal. And another thing is regarding our AMDA project that we were supposed to take on. I'm still waiting on. You said that we need the IRB approval for us to go ahead regarding that observational study that we are going to take part. So if you could kindly update regarding that, that would be really great. And I think, just to, that's it.
No worries. Thank you so much. And great as far as first project. So the paper, if you keep me updated, I'll look at it and we'll give you the feedback, and good luck with that. That's great. Excellent. As far as IRB, I will look into that and update you as well.
Sure. Great. Thank you so much, Dr. Nadir.
Excellent. Thank you. Anybody else? So again, if you have any projects that you already submitted to any conferences and you have either positive reply or negative reply, please send me a copy of these emails or responses so that we can keep track, and also we can help identify what areas we can improve on. Maybe we need to tweak a little bit of the poster, for example, the abstract, and submit it to a different area or conference. Same with the manuscript. If we are submitting to some journals and we did not get the acceptance, maybe we can work together. So keep me posted and we will either edit, modify, improve, and then find another journal to target for the next step. So excellent.
Anyone else would like to update us with their projects?
So in 2 days, there will be the deadline for the Alzheimer Association International Conference, and that will be in, I think, in the Netherlands, but also virtually. So if anyone has any ideas or ready or semi-ready abstract that we can submit to the Alzheimer Association, please send me an email today. If you are interested in working with some of the projects, also send me an email. We can work on something and send it to them. The deadline again is in 2 days. So the earlier you let me know, the better. Thank you. Any other updates or questions?
If no, I think we can conclude this meeting. If nobody has any other updates.
All right. Thank you again. Thank you, everyone. Thank you, the presenters, all of them. And thank you, Dr. Eiman, for great promoting this or moderating this conference or Zoom meeting.
Thank you very much.
Thank you. All right. I'll see you next week. Keep me posted if you have any questions or call me, text me. I'd be happy to answer. Have a wonderful day. Assalamu alaikum. Good night if you are far away.
Assalamu
Assalamu
alaikum.
Assalamu alaikum.
Thank you, Dr. Nadir. Alaikum assalam.
Thank you so much, Dr. Isra.
Thank you so much.
Thank you, Dr. Mohamed Osman. Assalamu alaikum. And Dr. Mfaz, if you're still there.
Yes, Dr. Nadir. Hello.
Assalamu alaikum. How are you?
Alaikum salam.
Very good. I got your email. So you submitted, you divide the abstract into 2 and submit to
No,
places, right? Or not?
the one that was accepted today was the one that's the original one, the comparison.
Oh, both of them.
Yes.
Oh, that's great.
Yes.
Excellent. And we verified that.
I tried my best to verify, but I'm worried. So I would rather if I could get your help in taking this verification.
Okay.
Yes.
All right.
But
So
also,
we will,
yes.
Yeah, we'll look it up. Yeah.
Okay, that will be great. And now we finished the geriatric, the separation, the geriatric abstract, and inshallah, like soon we'll be also submitting it. And then I have this.
If you submit me, if you send me a copy of that, maybe we can modify it and send it to Alzheimer. I'm not sure, but
yes, I'll send it to you. I'll send it to you right now. Yes.
Sounds good. Yeah.
Thank you.
And do you have a question?
Oh no, that's it.
Okay. Thank you so much. Have a wonderful day.
Have
Bye-bye.
Bye bye.
Assalamu alaikum. Dr. Amal, how are you? If you're still there.
Hi, Dr. Nadir. I'm fine. How are you?
Excellent. Any updates as far as the app?
So we decided to upload our application as free template in Glide, and we also start writing the abstract soon, inshallah.
Excellent, excellent. That's great. So I think the steps for the Glide app, I think it's straightforward, if I'm not mistaken, at least at the time when I did mine. So try it. If you have questions, let me know.
Yes, sure, inshallah, Dr. Nadir. Thank you so much.
You're
So
welcome.
I have question about the upload in Google Play or App Store. I'm not sure if this is straightforward or if this is available. Can I do this or there's
yeah,
problem
there
with
is
that?
a way. There is no direct way. Like the simplest way is Glide App Store. The Google Store, I think it's easier than Apple. And there is a way of modifying this using a different app and then submitting that app to the Google Store. So if you want to do that route, we can work on that. So it may take a little bit of different steps, but it's doable. Last time I did, I think they have some requirement, but we have to figure it out. I don't think it's complicated.
Yes, I have read about this, and there is, I think, an application or a program. Yes, that is called Nativator.
Just a second.
Okay.
Sorry about that. Go ahead. Amal? Hello? I can't hear you, Dr. Amal. السلام عليكم دكتور أمل.
عليكم السلام دكتور نادر.
أهلا.
So just I wanted to tell you about that. I have read about the steps of publishing the application in Google Play and App Store. So I have to use a website called Nativator, I think. So
it sounds good.
Yes, I'm not sure if you can hear me or not because I can hear a sound.
Sorry, I have a background noise, but
No
this is
problem.
great. Yeah. So if you can try that, let me know if I can be of help and just keep me posted.
Okay. Yes, I'll try that soon. Thank you so much, Dr. Nader. Thank you for your time.
You're welcome. Thank you, and good luck. Wishing you all the best.
Thank you so much.
Everyone else, any questions, any comments, ideas? If no, we will see you next week.